Hello and welcome to episode 5 of the Rogue Health Economist. I'm your host, James Maskell, and today's episode, we're going to be talking about primary care. The title of this episode is Primary Care is Dying. Should we resuscitate? It's going to be an awesome event. We've got some great stuff coming up for you, and I'm super passionate about laying it down. In this event, we are going to be talking by the end of it for my thesis on where primary care should go, what's working, what's not working. But we would love to hear from you. It's been amazing to get so many messages from you about the content, what you like about it, what you don't like about it, and continuing to work in that matter. So I just want you to take a moment, as you're the person listening to this. What has primary care been like for you? Do you feel heard? Do you feel like there's some plan that's being come up with to help whatever you came in with? Right? Do you feel that it's taking up the vast majority of your day for a very short appointment? What's changed in the time of COVID? We're going to talk about telemedicine. We're going to talk about lifestyle as primary care. There's going to be so many good things that we're going to talk about in this episode, and I'm really glad that you're here with us. So I want to start off with a great quote that I came across from Gary Hopkins, who says, "Our primary health care should begin on the farm and in our hearts, not in some laboratory of a biotech and pharmaceutical companies." And I love that quote, and we're going to think about that today as we move forward. So at the end, we're going to talk a little bit about what it's like to be a patient in the system, but what's it like to be a doctor, right? What's it like to be a doctor participating in medicine today, and particularly in primary care? There's a new film that's coming out called Do No Harm. And they're doing screenings every weekend. And there's one coming up this Sunday. And you can check out the film and you can do an online Q&A with the producers. Let's check out a little bit of it here.
Hi, Pamela. We just had another doctor jump and commit suicide from Mount Sinai. This keeps happening, and they're just covering it up.
If we had this number of patients jumping from hospital rooftops, there would be an investigation. Why are we not taking this seriously when these are doctors and medical students?
We're going to be looking at two things: the posture on the wall.
Everybody understands that medical school is very demanding. Those demands have a profoundly toxic effect.
Doctors have felt that they need to start running faster, seeing more and more patients.
All of this pressure happens, and there's no margin for error.
Take care of people who die. It like erodes your spirit.
Workload, isolation, sleep deprivation. It is a time bomb.
It really is almost like tunnel vision. The only way that I logically was thinking at that time was
to end it all.
Break down in my room every night. I never wanted to die. I just wanted to stop suffering.
People believe in you because you are perfect. Death sometimes feels like a safer option than having that mask uncovered.
The medical profession has launched a campaign to reduce the high level of suicide among doctors.
This qualifies, in my view, as a pandemic.
The biggest risk is patient safety.
Medical errors are now the third largest cause of death behind heart disease and cancer.
If you have somebody that is not functional either mentally or physically, then you can't have good quality care.
I've seen a resident be in a surgery, falls asleep standing up.
So my first question is, how come this story is not on the front pages of the papers every single day?
If a third of them are suffering from clinical depression, that should be known, that should be exposed.
Our son Kevin was a fourth-year medical student who took his life on April 23rd, 2015. I realize this has been a problem for decades and nothing's been done about it.
We are not ashamed, and we're going to do anything we can to keep others from having to go through this, because I'm going to tell you, it's hard.
Cultures and institutions don't change because we ask them to change. They change when they're forced to change.
I've read the petition, and we're already doing what they're asking.
I think if you were to really take on physician suicide with the seriousness that it needs to be investigated, it would take our entire medical profession down to its knees, and we would have to rebuild from the bottom up.
Take the medical profession down to its knees and rebuild from the bottom up. Those are words from Dr. Pamela Weibel. And I first met Dr. Weibel in 2011 when I spoke at my first conference that was for primary care doctors. It was called Heal Thy Practice. And I learned things about primary care and about the state of medicine in America that have pushed me forward every day since then. Now, I am clear that in other places around the world, the primary care relationship adds an immense amount of value. And there's plenty of studies to show that the quality of people's health experience is reflective of the quality of primary care. But I want to be super clear now that that is not the case in America. In only very, very few situations is there real value being delivered in primary care. What I learned at that first conference that I want to share with you here today is that modern primary care in America is a massive scam. And it's a massive scam that goes like this. Well-intentioned doctors running primary care practices. Why do you choose to practice primary care? It's because you care about people, right? You obviously don't care about money, because if you cared about money, you'd be a specialist. Right? You care because you want to help people and you want to be face-to-face with people with their problems. The best doctors I know, some of them wanted to be primary care doctors to help, to be generalists, to help families. Family medicine is the same thing. So then what happens? You're working in your practice, and the onerousness of billing insurance and doing all the back-end stuff, billing this to only get paid this, only getting paid months down the road, the heartache, the hardship of running an independent primary care practice gets too much because the dollars go down and down and down that you get reimbursed. You can't build a business on top of that kind of thing. You can't be an entrepreneur on top of the regular, primary care system. It's impossible. And so what happens? You get a lovely offer from a local hospital system to sell your practice to them. Because guess what? They're going to take care of all the billing stuff, and they're going to take care of all of that stuff, and you can outsource it all, and you're just going to get a nice, clean salary, and probably not a bad salary. So that looks really, really good to take all of that pressure off, all of those details. So you sell your practice. And I heard this story a half a dozen times at that conference, and I've heard it 100 times since then. So what happens? Now you run a primary care practice that's been sold to a hospital, and for the first 6 months, it's pretty cool. You're enjoying being an employee. You just get paid every month. You come in, you do your work, you leave. You don't have the headaches of being an entrepreneur. But then you have your meeting with someone from the hospital, and he says, Doc, you know what? It doesn't look like you're sending enough patients to our pulmonology department or our radiology department or our nephrology department, and we need to get more people in there. So you're going to need to improve. And actually, we have a quota for you now that we want you to fill. And if you don't fill that quota, you may be subject to losing your contract, and we'll hire a junior doctor who will do that. I can't tell you how many times I've heard that. Now, where that's even more painful for doctors is when, in my world, they've gone above and beyond to learn about lifestyle ways to deal with primary care issues, right? To help people with their sleep, and to help people with their food, and to help people with their nutrition and lifestyle and sleep and stress and relationships. And you go that way because you know that you can help people, only to find that if you get people better at primary care, you're not fulfilling your contract with the hospital that you just sent your patients to. And this leads to the most horrific perverse incentives. Whereas when you go and see a primary care doctor now, you have no idea what the incentive structure of the doctor is. And if you're getting sent into having care that you don't know what it's for, now you can understand why. And here we are in COVID, and we see that all of this medicine is not happening, and by and large, it's not that bad. And it gives you an idea of how much medical care is actually necessary and how much of it is completely superfluous. That is happening right now because it's being exposed by the fact that here we are right now where no elective procedures, no appointments in hospitals outside of COVID are happening, and it's not all that bad. In fact, medical deaths, that they said in that video, the third biggest cause of death in America is medical deaths, iatrogenic disease. Disease as a result of drugs and doctors is through the floor, right? Because doctors aren't doing as much stuff as they normally do. So in this moment of COVID, something is happening in America to primary care. And I want to share with you a little bit of what this is. So this was in just yesterday in the Washington Post. The pandemic could put your doctor out of business. Primary care practices were barely eking by. If patients stay away too long, they'll crumble. So this was written by a doctor who works, I'm lucky to work in a well-funded non-profit hospital system. So don't get me started on a non-profit hospital system, because you can see from Indiana or otherwise that being a non-profit is no sign of doing good in society. And in fact, the biggest gouges of your health insurance premiums are these non-profit hospitals. You can Google it, look up what happened in Indiana. It's a complete scam. And he says, where expensive advanced testing and difficult procedures like bone marrow and heart transplants help subsidize the money-losing work my primary care peers do to sustain the health of our communities. Is this the best that we can do, right? Is this the plan moving forward, subsidizing the stuff that actually creates health by the stuff that is, he gives the example of difficult procedures like bone marrow and heart transplant. Think of all the other stuff that's happening, right? That's some examples of like, he's looking to portray himself in a good light. And read this, we project a 50% loss in patient care volume over 3 to 4 months, which will have a major impact on the $1.2 billion annual revenue our 2,900 physicians bring in. We're going to talk about that in a minute, and what percentage of that $1.2 billion of annual revenue is actually going to the doctors, and what is going to everyone else in healthcare that doesn't do anything to create health. Also in that lecture down below, there was a quote from the incoming chief executive of the American Academy of Family Physicians, who says, primary care is comprehensive, continuous, holistic, portable, and patient-centered, while fee-for-service is focused on units of care, units of time, and sites of service. So we have two things that don't match: the way that primary care is paid for and what primary care should be doing. And this is the question that we want to ask. If primary care, in the way that it's being dealt with and the way that it's being delivered up until now, might be going away, should we bring it back, right? Is this what we want in the future? And ultimately, we can see that maybe there is a different way of doing things. So there have been some ideas coming up. So Dave Chase is a great thinker, and he's got this group called Health Rosetta. And I super respect all the people in that group. And they've come up with this idea of a primary care Marshall Plan, where essentially, insurance companies that have got all the money because we're paying in all these premiums and we're not using the services, that they should be paying primary care doctors sort of like a dividend over this time to keep them in business because they need them. And this is a decent idea. And I think it's a good way to transfer some money to primary care while their clinics are closed. But ultimately, I want to go a little bit deeper into what a possibility could be. This pie chart showcases that 73% of our national health expenditure goes to anything apart from health providers. So that's the big red chunk in the middle. 7.3% goes to physicians, 6.1% goes to nurses, and then all the other types of health professionals get the rest of that, multicolored chunk there. So what is happening with that 73%? And is that really necessary? We built this whole infrastructure with insurance and hospitals and administrators and everything. It doesn't create health at all. And this was in my book, The Community Cure, because when I saw this graph in 2015, it shook me to my bones. Because even if you go to the doctor and they are able to find the issue that you come up with, like the modern primary care system can do one of two things: deliver on a pharmaceutical prescription, right? In 7 minutes, what can you do? You can listen just long enough to anchor some symptoms into a diagnosis and give a drug. Or two, you can send them on to a specialist. And we already decided, I already shared with you some of the perverse incentives that are happening in the background of that kind of transaction. So let's say if we give them a drug, how's that going? This is from Nature in 2015. It's called Imprecision Medicine. I put it in my book. For every person they do help, Black, the 10 highest grossing drugs in the United States fail to improve the conditions of between 3 and 24 people. Health statistics in this country, and generally, actually not just this country, in the UK too, are by their very nature confusing, because we use things like absolute risk and relative risk. They're using it in COVID too to overstate the risk of certain things happening. If you look at this, which is the number needed to treat, which is a much better number. Look at Nexium, right? This is a thing that's used over and over again for digestive complaints. That is 1 in 24 people that actually helps. Crestor, one of the best used and most regularly used statin drugs, over 1 in 20 that helps. Look at Abilify, Humira, right? Humira, number 3. We talked about the cost of autoimmune disease. We had a whole episode looking at the new understanding of autoimmune disease and how it is triggered by environmental factors and gut permeability. Humira costs $5,000 a month and only helps 1 in 4 people. And you can see those different numbers here. So even if we get the diagnosis right, the number needed to treat shows that it's not working that well. And this is what primary care is today. Do we really want more of this? I want to take you back to what I think primary care could be, right? What are some principles that we can base the future of medicine on? Right? If we were to build it from scratch, if we were to burn it down, it's not just Pamela Weibel on that video that's saying we could start again and burn it down. ZDogg MD said the same thing a couple of weeks ago, which is like, when COVID is done and we're done taking care of you, we're going to have a real conversation about what it's looking. You could see a general strike. You could see a general physician strike in this country because physicians have been abused in the system for generations, and they're not going to stand for it anymore. And ultimately, I wanted to come back to what are some principles that we would build. If we were going to build from scratch again, what would we build? And this quote from the Baghdad medical exam, AD 800, to me, is something that we could build on top of in the future. Anyone found to have used a strong herb when a mild herb would do, or a mild herb when dietetics would suffice, or dietetics when a lifestyle change would suffice, shall be disqualified from practicing medicine in the marketplace. Booyah! 800 AD, Baghdad medical exam. Are you kidding me? Like, this gets to the point, right? This is about using the least costly, least invasive interventions first and only going to the most costly last. Look at how primary care is today, right? We use the most costly, most invasive things first, drugs and surgery, right? If you refer up in the system, if you refer to the hospital, what are you going to have? Some sort of elective procedure. That's the stuff that's not happening today, those drugs and those surgeries, that's causing the rate of death as a result of drugs and doctors to go through the floor, right? And it's not the doctor's fault. Look at the video. Look at the stress they're put under. It's insane. Right? All of these things are totally insane. So this is a principle to build around. And what does this look like? Where is this being practiced in modern medicine? There is an idea in medicine called the naturopathic therapeutic order. It comes from naturopathic medicine. And whatever you want to say about naturopathic medicine, this, my friends, is an idea whose time has come. We should start with the least costly, least invasive intervention first and work our way up. So what does that look like? The first layer here is establishing the conditions for health. That is solving the social determinants of health. We have so much talk about what could solve the social determinants of health. We've got big organizations saying they're going to put medical money towards solving the social determinants of health. I'm glad they're talking about it, but it's going to be very, very difficult to do inside the current system. And I'm going to talk in a minute about the thesis that I have in my book for how to do it, and we're going to talk about it directly. Second, stimulate the healing power of nature. How do we self-stimulate the body? Once the social determinants are taken care, how do we stimulate the healing power of nature? You know, Jim Gordon, who runs the mindfulness-based stress reduction program, has taken group mindfulness-based stress reduction to Puerto Rico after the hurricane, and Gaza and Kosovo, and got an 80% reduction in PTSD by mindfulness-based stress reduction in groups. That is stimulating the healing power of nature. We are incredible healing machines, and we're not exercising that ability at all. 3, address weakened or damaged systems, right? That's nutrition, that's building function. Earlier this week, I did a whole session on functional medicine and why I believe functional medicine is the operating system for the future of care. It's because it does those 3 things. It addresses weakened or damaged systems. The 4th layer, and this is where you might get into individual care, and we'll talk about this in a minute, is structural integrity. So chiropractors, osteopaths, physical therapists, massage, like sometimes we just have to deal with the structure. Structure leads to function. And then part 5 is addressing pathology naturally. So that would be kind of like your functional medicine doctor appointment today. And then the 6th is in addressing pathology and with synthetics, and that is pharmaceuticals basically. And only if we've used all of those options for chronic disease do we go to suppress or surgically remove pathology. You can see that with the medical system set up the way that it has been, we're doing this the opposite direction, right? You get recommended to go to primary care. They have to put you through because they've got a quota and they send you to a specialist. They recommend surgery. Maybe you do it, maybe you don't. Then you get a drug. Then after you've done that and it hasn't worked and you're still feeling sick, then you would go to functional medicine. And only eventually would that functional medicine doctor tell you, hey, you may want to think about like sleeping differently, or more. 4 hours is not enough. You need to actually rest and repair the body. Or, you may want to start meditating because, your stress is causing all of these issues. 91% of office visits come from stress. We, ladies and gentlemen, need to disintermediate this whole process, right? We need to take people to lifestyle stuff first, not last. Not the last thing after all these things. That is what is causing this insane cost creation. This system, someone says healthcare is broken. My buddy Sachin Patel retaught me that healthcare is not broken. Healthcare is fixed. This is fixed. This is the plan, right? This is created to make unbelievable amounts of money. That's why we spend 20% of our GDP in America on healthcare, because the system is fixed to maximize revenue, not maximize health. So maybe we do need to burn it to the ground. And I'm here today to say that I don't think we should resuscitate primary care. I don't think that it's a power move for us to be able to work on it. And if you really want to know, those of you who are doing it, like I've been in the business of helping doctors to build this new system for a while. And, we've helped in my book, The Evolution of Medicine. We've helped dozens of doctors, if not hundreds of doctors. We had almost 1,000 doctors go through our practice accelerator, where we're teaching doctors to build new practices of the future. And what is this new practice of the future, right? Think about this new concept called direct primary care, right? Direct primary care, you get rid of all of the middlemen and you have a direct relationship between the patient and the doctor. You disintermediate the health insurance, all the people. And how do you find those patients? You go out and you actually add value to people in the community. How are people building these businesses? How are people getting people to pay directly for direct primary care? You get out into the community and you showcase people how to keep themselves healthy. You add value just the same way that every other business does. And we've helped doctors get out into the community, talk about how to keep yourself well, and build these digitally involved functional medicine practices that are solving chronic disease and getting money from people directly. Now, does direct primary care have to be expensive? Is it in the range of pricing for people who are on Medicare or people who have lower incomes? Absolutely. The non-functional medicine direct primary care practices, the pricing can be $50 to $80 a month, right? Think about, you spend more than that on a copay, right? You could spend more than that on the copays for your drugs and the price for your drugs you're taking. Like, why wouldn't you do that? So, direct primary care is an example of real value, disintermediation. And guess what? 100% of that money goes to the physician, right? Yeah, he's going to have to pay some people in his staff, but Pamela Weibel shared with me that when she went from her primary care practice to a direct primary care membership practice, she went from 74% overhead to 10% overhead, right? All that money is effectively a waste. It's not creating any health. And those doctors in our network that today read this, built their practices around it and used this pilot guide, who have a digitally advanced, telemedicine focused practice, are all thriving during COVID, are open for business, get paid every month, are being generous to their practitioner community by doing webinars and teaching them about what the truth about COVID-19 and how to keep themselves healthy. They're in a position because they are getting cash every month. They're not dependent on the rest of the healthcare system. So let's take it back to, to the patient point of view, right? What's it like to be a patient of primary care? So I know from being a patient of primary care, you get rushed. The doctors don't have time to do anything to do with lifestyle. I spoke to some of my team this morning, and their experience is like, thank God for COVID, because now everyone's doing telemedicine. Mothers who used to waste a whole day, for a doctor's appointment that took 7 minutes because the doctor was running back. Now they can do it at home from telemedicine. They're so thankful that this has come along because you're respecting people's time, right? And the most frustrating thing you get at primary care, more than here's the drug or you've got to go to a specialist, is let's just wait and see. Let's see what happens. Maybe it'll get worse, maybe it'll get better. Really? Is that the best that we can do? Right? Is that really the best that we can do? The best that we can do is to solve chronic disease at primary care. That is what we need to do. And that was the thesis in my first book, The Evolution of Medicine, and my new book, The Community Cure, that came out on the 14th of January this year. And this is my thesis, right? If we're going to build healthcare from this ground up, what are we going to do? Now, this thesis is built on the concept of the naturopathic therapeutic order. In the same way, we want to start with the least costly, least invasive interventions first and work up from there. The least costly, least invasive intervention is changing and creating a culture of health, right? And you can do that. If you run a direct primary care practice as a doctor, you could put out content to change the culture of health. We could be doing that with the media, not this fear porn that we have every day. If we were able to change everyone's behavior to stay inside, we could change everyone's behavior and tell them, guess what? If a vaccine comes along, the vaccine will work way better if you are metabolically healthy. And by the way, as we showed yesterday on the show, you have a 10 times increase in chance of death if you have metabolic abnormalities caused by lifestyle. So let's use the power of the internet. Let's use the power of public health to create a culture of health. Now, for some people, that's enough. They're just like, okay, James, I get it. Like, I need to disintermediate from the medical system and I need to focus on lifestyle. I can do it. And they're on a trajectory to health forever. But if it was that easy, we would have already done it. Stage 2 is community. And that's why we're really focused on group medical visits. I've said it before this week, and next week is going to be all on community. Every episode, we're going to be diving into different areas of community. We're going to be talking to Dr. Cheng Ron. He has pioneered a type of virtual group visit with remote patient monitoring on Medicare that is working for him in practice. So groups of people, supportive communities. Lifestyle-driven chronic disease is more like alcoholism than it is like infections. Let's give people support and accountability, not drugs and doctors. The third thing that we're going to do, the third layer, the third cheapest layer is coaching, right? And coaching can be done in groups, but also the power of health coaching. There is great research now that health coaching is really showing up to help people change behaviors, and coaching generally. Like, this didn't come from healthcare, this came from business, because business realized before anyone else that changing behavior can have an impact on the bottom line. So coaching, and then only then, with 3 new layers outside of it, do we get to care. Do we get to doctors and medicine and surgery and all of that kind of stuff. This was the thesis in my book. This is what I believe is the future of healthcare. We are hearing doctors saying we need to burn this down and start again. And I don't blame them. What's it like to be a doctor in this session? It sucks. And what's it like to be a patient in primary care? It sucks. Primary care around the world. My mother lives in England. She has a GP in the NHS who she loves. That is a reasonable use of primary care. I still think there's a lot of improvements that could be made there. And I've done a whole show on it last year on saving the NHS with groups. But here today, we are talking about the American primary care system. And my thesis, and I hope you agree with me here today, is that we need to be doing lifestyle at primary care. We need to be taking a root cause approach at primary care. And very soon you'll be seeing that we have a solution for that. Not just the thousands of doctors that are currently doing primary care on the front lines, but a solution for everyone to be able to access this type of care from their home. Watch this space. It's coming to you. This is episode 5 of the Rogue Health Economist. If things in this episode resonated with you, please share it. I feel like I've waited 15 years to give this talk, and I appreciate everyone being part of our community. We'd love to hear from you below. Have a wonderful weekend. I'll be back on Monday. Thanks so much for watching. We'll see you next time.